hematocrit. Okay? What is normal hematocrit? About 45. Okay. The normal hematocrit is, from roughly speaking, 40, even 30 is okay. Let's say 33 up to 50. In female, usually 48, and men 52. So above, let's just say, you can have hematocrit normal. Okay, so that would be the range. What if the hematocrit is bigger than hematocrit? Bigger than 50. Just keep it simple, 50. What would you call that? What if it's less than, the hematocrit is less than 30? What would you call that?
This is a percentage of total
RBC count.
Okay.
Okay. All right. Now, if you have too much RBCs, more than 50%, that means too many. That shouldn't be normal. So if you have too many RBCs in your blood, could that cause a problem? You're just saying because the range is above normal range? Okay, it is abnormal. Why? Good. Think about it this way.
The composition of blood is going to have more RBCs, so like less proteins, like plasma proteins, and like other.
See, it's a good attempt, but if you have more red blood cells, it's not going to push protein somehow out of the vessels. They'll still stay there. Everything will stay the same.
The viscosity.
Viscosity is the most important thing, exactly. So blood viscosity will increase. Blood is thicker now. Flow will be affected. Oxygenation will be affected. So blood viscosity. Okay?
Blood pressure.
No, blood pressure is not changed.
Acid base.
Nope.
Will change too. No?
So now, this is called polycythemia. We'll talk about polycythemia hopefully Monday. Okay? So too many red blood cells, the term for that is polycythemia. Less than 30%, you can call this anemia. But anemia is not only hematocrit is low. If the hematocrit is less than 30%, it's anemia for sure. But if hematocrit is normal, but the RBCs are misfunctioning, they're defective, that's still anemia. So anemia is a term that's used for defective RBCs in terms of function, in terms of number, in terms of quality. Any defect that leads to inability of RBCs to carry oxygen is known as anemia. So please don't mix anemia in terms of only with hematocrit. In general, most of the time when you have anemia, hematocrit is low. Okay? But anemia literally means no blood. Emia means blood, ag, no blood. Anemia. Anemia. Okay. In Latin or Greek, am means no, without. So anemia, no blood. But that's not true of anemia. The term anemia we use in medical terminologies and then in healthcare workers and everywhere else, it literally refers to any defect of RBC that leads to decreased oxygen carrying capacity. As long as RBC is unable to deliver oxygen to the tissue, it is called anemia. Are we good with that? Okay. So I wanted to talk about this just so you understand, what is polycythemia, what is anemia. And between the 50 and 30 is normal. So since today we're talking about hemolytic anemias, let's go talk about anemias. I think the first page in your book, after all of the physiology, you should have anemia in general. Okay? Anemia in general. Now know this, we need to understand this part first, because after that, what is the exact cause of anemia? All the symptoms will be the same. So let's spend time on anemia itself first. Although there's different types of anemia, I think 8 for hemolytic, 4 for microcytic, and 4 for macrocytic, something like that. So that's 8, 8, 16. 16 anemias you have to learn. Okay? But all of them have the same symptoms. The complications, their underlying cause, their pathology is different. So once you understand anemia, then you will focus only on underlying cause and pathology and things like that. Right? Okay. So, in your book, it states that, so you should know whatever I stated earlier, anemia means defect in RBC function, RBC structure, RBC shape. So anything that will lead to RBC misfunctioning, that's anemia. Okay. So what are the underlying causes of anemia? In your book, when you have UNC, that stands for underlying cause. Underlying cause. Okay, so that stands for underlying cause. Now, what are the underlying causes of anemia? What do you think?
Iron deficiency.
Iron deficiency, that's one. Excellent. Iron deficiency. So that's one type of anemia. And let's do that. Iron deficiency. Anything else?
Folate deficiency.
Folate deficiency. Think of one more deficiency then. One more deficiency.
B12.
B12. Why should I be 12? Can I be 10?
Sure. How do you want to make it?
Vitamin B12, that's what he means. Vitamin B12. Vitamin B12. Okay, anything else?
Trauma.
Trauma, excellent. Anything else? Is there a specific condition that's very common in African American?
Sickle cell anemia.
Sickle cell anemia. Very good. Sickle cell anemia. Is there a condition that's specifically common in the Mediterraneans? Thalassemia. Is there another condition that's common specifically in Asians? A for A, Asians. Alpha thalassemia. So beta for Mediterraneans. Alpha thalassemia. Okay. Is there one more that's common in Libyan, Egyptian, Turks, Portuguese, Spanish, and Greeks, and Italians? Glucose-6-phosphate dehydrogenase deficiency. Very good. Okay. But in general, you should think of it this way. Iron deficiency, folate, B12, trauma, these are acquired. Acquired anemia. You're not born with it. They are acquired because of diet, maybe because of bleeding, iron, B12, and trauma. These are all acquired. Sickle cell, thalassemia, glucose-6-phosphate, all of these are genetic. You're born with these. Okay?
So all the ones without the minus sign, those aren't deficiencies, right? Or are those an overproduction of RBCs in that case? Macrocytic, right?
Never overproduction. It wouldn't be anemia. It would be called polycythemia.
Polycythemia. So anything.
There's no polycythemia in this list. It's all anemia.
Okay, so
Now, the cause of sickle cell, okay, the cause of sickle cell anemia is hemoglobin defect. The cause of thalassemia is hemoglobin defect. Glucose-6-phosphate dehydrogenase is an enzyme deficiency. Right? I'll discuss that, the underlying causes. I just want to tell you general anemias right now. General. Okay, so I don't have to repeat myself every single, there's 20 anemias. I don't want to repeat myself 20 times. It will take us 20 days. So I want to give you anemia in general, and then I'll tell you specific of each, and then you apply. Okay? So what's different between all of these anemias? Their underlying cause, their pathology. Symptoms are not different. Anemia is anemia. Tests might be maybe a slightly different. We'll discuss those. Okay. How about nocturnal paroxysmal hemoglobinuria? That's another one. Also genetic. aplastic anemia could be many things. It could be acquired or genetic. Hemolytic anemia, these are all, the genetic ones are all hemolytic anemias. Yeah, hemolytic dysentery means RBC normals. Yeah. So I want to come to that today. Okay, now, so these are the causes. Pathology of each is different, so I'm not going to discuss that in here. But to give you iron deficiency anemia, their pathology is without iron, heme cannot carry oxygen. Without iron, heme cannot carry oxygen. We discussed that yesterday. That is the iron that binds oxygen and carries it to tissue. So if you have less iron, the entire hemoglobin is useless. Right? So it won't be able to carry oxygen. Almost like stating, look, if you have a car, the floor of your car is all full of pointy objects. You cannot sit in that car unless you have a seat. The seat is the iron. If you remove that seat, this car cannot carry you. So a hemoglobin without iron can't carry oxygen at all. So we'll have a defect. But anyways, now risk factor will depend on each of these. For iron deficiency anemia, the risk factor is mostly female. So that's a risk factor. Bleeding, menstrual cycle, those are risk factors. Again, we'll discuss that in iron deficiency specifically. Folate deficiency anemia. Folate, think of F, fruit, vegetables. People who are vegetarian. People who don't eat enough vegetables. They're at risk of folate deficiency. People who don't eat enough vegetables, green products, they're likely to develop folate. Okay? And mostly elderly female, malnourished female, alcoholics, they're at risk. For B12, who's at risk? Vegetarian. People who don't eat any sort of beef, because B12 is primarily found in beef products. Okay? Again, alcoholics. If somebody's alcoholic and they're vegetarian, they're 3 times more likely to develop B12. But B12 is not known to be mostly caused by diet deficiency. Number one cause of B12 is known something as pernicious anemia. It is autoimmune. Again, we'll discuss that in detail. So risk factors. Trauma, of course. Marathon running, motor vehicle accidents, extensive exercises, it can lead to anemia. Okay? Now, if somebody goes and suddenly starts working out crazy, and you wake up in the morning, and your urine is dark, that's because hemolytic anemia. Okay? And I'll discuss that. Sickle cell anemia, the cause of that is a mutation in the beta globulin chain. Mutation in the beta globulin chain. Now you don't have to write them because it's all in your books. I'll go over each one of them. I just want to set ourselves for something so that we can relate to them later on. Look, sickle cell anemia is nothing more than a mutation in the beta globulin chain. If the beta globulin chain of hemoglobin is defective, it's unable to carry oxygen properly. And when it does, it's not an issue. The issue is when it deoxygenates. When it deoxygenates, it forms an aggregate. It polymerizes. And it clumps together, that hemoglobin. That's what your focus should be on. Thalassemia. Beta thalassemia. What do you think the defect is? It's hemoglobin. Which unit? Beta. Alpha subunit. Now in beta and alpha, it's either alpha is completely deficient or beta is completely deficient or partially deficient. Okay? Glucose-6-phosphate dehydrogenase, you have the enzyme that's deficient. As a result, you cannot neutralize free radicals to protect RBCs. Paroxysmal nocturnal hemoglobinuria, CD55, CD59 are not able to attach to RBCs and therefore protect them from complement lysis. In plastic anemia, aplastic means, see plast, what does plast mean in pathology? Make, change, growth, increase in number, all of that's correct. So most likely plast means characteristics of those that have a high division rate or mitosis. Aplastic, no mitosis, no division, which means the blood cells are unable to divide. So aplastic anemia is usually caused by damage, for example, damage to bone marrow. People taking radiation for lung cancer, breast cancer, things like that. Or taking medication. Do you guys remember any medication that can cause aplastic anemia? Cyclophosphamide, for example. Okay. Sometimes benzene was used to be used, and that can cause it. There's a lot of drugs. Parvovirus B19, the virus can cause aplastic anemia. Okay, so aplastic anemia means no blood cells can be formed. Platelet deficiency, red blood cell deficiency, and white blood cell deficiency. Okay. Anyhow, so these are the anemias. Now, let's go. So when we think of anemia, hematocrit less than 30%. That's one. You can have hematocrit less than 25%, and then less than 20%. So it's a spectrum. It depends. If your RBCs are within 30 and 25, it'll be mild anemia, right? So mild. Less than 25, moderate. And then less than 20, severe. So, symptoms of anemia depends on severity or lack of RBCs, number, function, structure, shape, whatever. But what is the function of red blood cells? I don't have to tell you this, and you don't have to memorize, because by now you know what's the function of red blood cells. Carry oxygen. So if you have less than 30%, are they able to carry oxygen at the same rate, as efficient as before? No. So what do you expect? What would you expect? You tell me. As symptoms. How would what would I experience at that point?
Fatigue.
Fatigue. Why fatigue?
Less oxygen means less energy.
Less oxygen means less ATP. As a result, if you have no ATP, no energy, you will feel fatigue. Hypoxia. Hypoxia, okay, that's a sign. So let's include it in here. All of them would have hypoxia. All of them. Okay? Hypoxia for all. So you can write that. Hypoxia for all. And the symptoms are because of hypoxia. Hypoxia means lack of oxygen or less oxygen delivered to the tissue. If there's less oxygen in air, that's not hypoxia. Hypoxia means less oxygen being delivered to your tissue. If your tissue is not getting enough oxygen, that's hypoxia. Although you might have tons in air.
Less erythropoietin.
Nope. See, erythropoietin is a hormone that is used to increase RBCs number.
It stimulates the bone marrow.
Yeah. So if you have hypoxia, wouldn't that increase or stimulate erythropoietin production?
Yes.
Yeah. As a matter of fact, erythropoietin should be increased.
Pale skin.
Pale skin, yes. This is the first sign. This is what people see the most.
Temperature sensitivity. Like feeling cold. No.
Also, don't you develop like white little like marks on your fingernails?
Yes, if you have chronic anemia. Good. So we'll put that in chronic anemia, long term. Long term. Okay? So now, pale skin, pallor, pale skin. That's the first thing we see when somebody has less red blood cells, less oxygen in their body. Please don't confuse pale skin with yellow skin. Both could happen because of anemia. Yellow is only referring to hemolytic anemias, because that's jaundice. Yellow and pale are two different things, but sometimes students will confuse the two and they think it's the same. It's not the same.
Well, jaundice, the eyes will also change.
So how do you distinguish between both?
Huh?
How do you distinguish between?
Yellow is yellow, pale is lack of redness. See, pale is not yellow. Pale is your normal skin, but it doesn't have the redness to it. Yeah. The best way to refer to pale, when somebody appears pale as if they're really sick. Yellow, they don't appear sick, it's just the skin color tone is a little bit yellow. So fatigue and pale. Now usually these are the two most important symptoms of all anemias, because anemia rarely get to severity because they're treated properly. So this is the two that you will see in questions most of the time. Always focus on fatigue and paleness. Okay? if anemia is, I mean, you can also have the fatigue is usually exertional. What does that mean? When you do some activity.
Weak. Start to atrophy.
No. No. Atrophy has to do with contraction, nothing to do with lack of oxygen. Okay? It has to do with muscle contraction. If you just lay down in your bed for 100 years, yeah, you will atrophy. If you don't use your muscles.
Well, I mean, if you're tired, not using muscles.
No, your muscles will still have tone. You will still be doing some daily activities. As I said, if you stay in bed for 2 weeks straight, your muscles will atrophy. If you can, but you can't. Your body won't allow it. Fatigue and pale skin. Now, fatigue is on exertion. When you do some activity, you will feel fatigue. Otherwise, if you're just sitting, you'll be normal. So that's not that type of fatigue. You can have lethargy. Lethargy is more like the sensing, the feeling of fatigue. That's not exertional. Here when we talk about fatigue, that's exertional fatigue. When you're walking upstairs, downstairs, or you want to run, you feel fatigue. Okay. In moderate cases, let's say this less than 25%, the symptoms become a little bit more severe. So now you will have maybe lightheadedness, dizziness, shortness of breath. What's the term for shortness of breath? Let's use that. Dyspnea. Now, when you go to less than 20%, you can have cyanosis. Can have it 20, sure. Cyanosis. Your skin can turn blue. And you can have murmurs. What's murmur? Abnormal blood flow. Harsh blood flow. You know when water is flowing with speed and it's harsh, you go to a river, it makes sound. When water is not flowing, it's just standing still, it produces no sound. So in anemia, because there is less RBCs, viscosity decreases, blood will flow faster. So cyanosis, murmur. CNS symptoms like confusion. And you can have, in this case, severe dyspnea. Not just dyspnea, not just shortness of breath. So here is on exertion. Now you can have severe dyspnea. So the symptoms will become severe as you go less than 20%. If it's less than 10% and more, you can even have syncope. What's syncope? Passing out. Because lack of oxygen to the brain is no longer functional, you pass out. Yeah.
So as you go from mild to severe, do the symptoms carry over? Do they still, so like, will severe still have paleness?
Of course, all of that will.
So all of that carries through.
Okay. In the murmur here, please write it down if it's not in your book. Write flow murmur. The murmur is specific murmur, flow murmur, meaning it's not due to valve defects. It's because of blood flow, increased blood flow. Flow murmur.
Would there be an increased heart rate?
Yeah, heart rate will increase. Tachycardia, tachypnea, both will increase. Yeah. So there will be increased heart rate and increased breathing rate, of course, to compensate for the lack of oxygen.
Can deficiency of vitamin D have any effect on anemia?
Not really. Not really. Unless it's associated with another anemic disease, yeah. But there's no direct correlation. Okay. Now, in terms of complication there can be many. Number one complication of anemia is some anemia can produce increased bilirubin. Some anemia, not all of them, that's specifically hemolytic anemias. Bilirubin will increase. So that's complication. Now, you know what bilirubin is by now because we discussed it yesterday. So what could bilirubin do if it accumulates in your skin? Jaundice. Okay. So that's one thing. Second thing, bilirubin is cleared by which pathways? GI. 99% of bilirubin should be cleared by the intestine, especially if it's conjugated. Okay, so majority of bilirubin should be cleared in stool. Remember I told you it's stool, the brown color of stool is because of bilirubin. Because of bilirubin. So it should be cleared in stool, bilirubin. Okay. Therefore, if you have too much bilirubin, how does it go from, where is bilirubin conjugated?
In the liver.
In the liver. How does it go from liver to intestine?
It gets secreted into bile.
Bile. Very good. So now there's one more thing I didn't discuss yesterday. So imagine this is the liver. Okay, and there is something known as gallbladder in green. Let's just color it green. So gallbladder, what happens is with bilirubin, it is secreted from the liver and bile ducts joined with cystic duct. So gallbladder is simply a place where you store bile until you need it to use it. So bile is a mixture of bilirubin, cholesterol, and bile salts. For now, as long as you know, a huge percentage of bile is made of bilirubin. Is that okay? As long as you know that a huge percentage of bile is made of bilirubin. If you have too much bilirubin in bile,
Bile stones.
what could happen to bile?
Stones, right?
It could solidify. It could precipitate and have gallstones. Gallstones. So one of the other risk factor of increased bilirubin production would be gallstones. Gallstones. Okay? Now, number one type of gallstone is, of course, cholesterol stones. Don't confuse them. Remember that. Number one type of gallstones, 90% of the time when there's a gallstone in somebody, it is because of cholesterol. So 90% of gallstones are made of cholesterol. 90% of gallstones are made of cholesterol. Only a minority of them is made of bilirubin. And that's only if somebody has anemia. So majority of bilirubin stones are because of anemic conditions. Does it make sense? Complication of anemia are gallstones. But these gallstones are bilirubin stones, not cholesterol. Okay, they are bilirubin stones. So there's two types of gallstones. So when I don't see a smile or something, I get worried, so I have to go further. So there's two types of stones, gallstones. Bilirubin stone or cholesterol. Okay. Bilirubin stones or cholesterol stones. The third type is a mixture of the two. Majority of gallstones are cholesterol stones. Minority are bilirubin. So that's one difference. In anemic conditions, these are not cholesterol stones. These are bilirubin stones. Okay? Bilirubin stones are dark in color. They are dark. Please remember that. They're dark. Dark crystals. Cholesterol stones are golden. Do you guys know the story of 49ers? No? In 1949? 1849? When did they start? 49? 1849. So whenever they were going for, for gold, all from New York, from here, from everywhere else, they would all go through, I think, Missouri, right? For Tennessee, they had to travel across. Back then, there were no planes and stuff, things like that. So what happened is, to go to this rough terrain, a lot of people would die. And then there were the native Indians who they would attack. So there were all these issues. So there were a lot of people who would go in the path to getting there will die. So a bunch of people came across and they see some people, they're dead. And they are searching for them, to take their equipment and stuff to use them because they're dead. Why waste the equipment and all that? So some people were eaten by wolves and stuff like that. Their stomachs were opened up and their gallbladder was opened up. So they see some 2 or 3 few people they see from their stomach. They see golden stones. The sunlight is hitting it and the golden stones shining. Wow, there must be gold here. Look, these people are eating gold. And they took those stones and put them in the things, and later they found out they were nothing more than gallstones. Gallstones are hard. They look like gold. They're hard and they look like gold. So they won't crumble if you hold them in your hand. They won't crumble.
That's for both bilirubin and cholesterol
I'm
stones?
not saying that. I'm only saying cholesterol.
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 Bilirubin don't look gold.
They are dark. They're not golden. So golden stone, cholesterol stone are hard. And they're not pigmented. So therefore, dark stones, pigmented stones, you can see on CT and X-ray. Cholesterol stones, you can't.
Why?
They're not pigmented. Have you guys ever seen a CT scan? Okay. Is your CT scan able to identify fat in your body? No. So would they be able to identify cholesterol stones? No. They won't be, they won't be, for example, hyperdense or hyperdense or something. They won't stick out. But on ultrasound, you can see all stones.
What about MRI?
MRI, no. No. So the best, and MRI is too expensive. You don't want to send somebody.
So what kind of scan can you see them in?
Ultrasound. Ultrasound. So always for gallstones, ultrasound is the test of choice, the first test, okay? The first test. But nonetheless, you should know this difference. In anemias, gallstones can be sensed by X-ray. You can see, diagnose, and test for them on X-ray. All right? Okay, 3 Musketeers. 3 Musketeers. Calm down.
Let's say the cholesterol.
Calm down. Don't distract each other. The 3 Musketeers, just don't look. Let them go. I'll do it. Yeah. Those 3 will not sit tomorrow at the same table. All you,
Well, I'm not
you
gonna
3.
be here tomorrow.
Okay, so there you go.
She's
One
distracting me,
less.
to be honest with you.
Okay, come back. Calm down. Now, please remember that gallstones in anemic patients are dark, they're pigmented, and they're made of bilirubin. Done. And they'll crumble if you touch it. Like sand. Okay, I wouldn't say soft. See, soft is a different. They will crumble. They're not fused together. They're not solid.
So it's brittle.
Okay. So that's one complication. Okay, that's one complication. Other complication that anemias could have is, for example, if it is in children, they can have something known as, because of indirect bilirubin. So that will be indirect bilirubin. Now, gallstones are of direct bilirubin. So let me put here unconjugated bilirubin or indirect. What's another term for direct bilirubin? Unconjugated. Indirect. Good. So indirect bilirubin can cause CNS defect in children only. Okay. Connectors, it can lead to mental retardation, things like that. So. Now, in anemia, what if the heme, what if your spleen is overloaded? It cannot break down all of the heme. So some heme will be then carried by blood. Remember that, the capacity of spleen to break down all of heme is limited. If you're lysing a lot more RBCs than the spleen can handle, obviously you'll have some heme floating in blood. This heme, the whole idea of breaking heme is because it's toxic. The whole idea, you have to break down heme because heme is toxic. So this heme can lead to many tissue, but one of the most important tissue is kidney. In kidney, it can cause acute tubular necrosis, and that could be deadly. Acute tubular necrosis. Acute, A, T, tubular, N, necrosis. So all anemia can do these, especially hemolytic anemias. Okay? In order to have bilirubin, heme, in plasma, the RBC must burst, must be lysed. Otherwise, it's entrapped within RBC, right? Okay, next thing. What are some tests that you will do to identify types of anemia? Okay, you can do CBC. What are you looking for on CBC? Hematocrit, very good. In most cases, hematocrit will be low. What else are you looking for?
Shape. And
Shape
size.
is on smear. So that will be peripheral smear. Okay, now the term peripheral means it's not bone marrow. Okay?
You just take regular blood.
You just take a blood and put it on a slide and look under the microscope. Peripheral smear is the best term, so if I use smear, I mean that's not conclusive, but bone marrow smear is different than peripheral smear. Peripheral means refers to circulation, plasma, blood. Okay? On peripheral smear, what would you see? I mean, anyways, it depends which anemia we have. So the thing we should be looking for is, here is shape of RBCs. Are they small? What is the term for small RBCs? Microcytic. How about large RBCs?
Macrocytic.
How about normal? Normal, I will know. Normocytic. Okay, so that's in terms of that. What if this is hemolytic anemia? Yeah.
Can you tell me the difference between the mean corpuscular volume and hematocrit?
Speak up, please.
Mean corpuscular volume versus
When you get there.
hematocrit?
When you get there. Yeah, just hold your horses. We'll get there. We're getting there. So in terms of shape, what else? What else could you see on smear? Hypochromic, excellent. Yeah, hypochromic.
Sickle cell.
Sickle cells, very good.
Wait, what's hypochromic, Dr. Moneer?
Hypo.
What does that mean?
Hypo means less, chrome means color.
Okay.
Yeah. So the red blood cells, you know, it has, the center is very red. How about this? Let me just draw one for you.
Not red.
Kidding. I believe you.
So this is a red blood cells, and you can see the center should be darker. When the center becomes a little bit lighter, this is hypochromic. So it loses its color because there's less hemoglobin there, right? Less hemoglobin means less oxygen. This red blood cell doesn't have enough oxygen to reflect a red color on itself. Yeah? Okay, hypochromic, sickles. Anything else?
Teardrop shape.
Okay, now we're talking about fragmented RBCs. Fragmented RBCs. You can see RBC that are fragmented. When you say fragmented RBC, what comes to mind?
Virus.
Possibly. Can a virus cause infection of, why not? No ribosomes. Never virus.
But isn't there a virus that causes
Aplastic anemia. It infects bone marrow. So as a result, you're not able to produce RBCs. But it cannot replicate within RBCs. Cannot cause infection of red blood cells. Unless the red blood cell is immature. Only immature erythroblasts can be virally infected because they have ribosomes, they have nucleus.
so those are the only ones that are segmented.
Segmented, yeah, sure. Not in that sense. It's not because it's segmented. RBC doesn't have to be segmented to be infected by a virus. Yeah. Segmented simply means that it has multiple lobes.
I remember a virus that used to cause RBCs.
Parvovirus B19
Yeah.
can do that, but that's immature red blood cells,
Okay.
not mature. So it causes aplastic anemia.
Okay.
So fragmented RBCs are, look, if this is a red blood cell, this red blood cells, what if I break it into pieces? Isn't that fragmented? When does fragmentation occur? Hemolysis. Fragmentation is a sign of hemolytic anemia. It's a sign of hemolytic anemia. That means the RBCs are lysed, broken down, ruptured, whatever term you prefer. But the medical term is hemolysis. Fragmentation is a term used for hemolysis, okay? But of course, fragmentation can result in different types of red blood cells. Some can be triangular. They can be triangular shaped. They're also known as helmet cells. But there's a medical term for that. Schistocytes. Schistocytes mean RBCs of variety shapes. That's what schistocytes mean.
Do they call it funny shape? Is that a different one, or is that part of the schistocyte?
Part of schistocyte. Schistocyte simply means that not all of the red blood cells look alike. Some are moon-like, some are circular, some are spherical, some are triangular, some are square, whatever. It just simply means their shapes are different. All red blood cells should have the same shape, right? All human beings have arms and legs and torso. They're all the same shape. Now, if you see a human being that looks like a cat or a worm or this, then you will say schistocyte. Yeah?
Bite cells, phagocytes.
Bite cells, excellent. Gee, excellent. Bite cells. Bite cells, so now bite cells, you have to remember this, bite cells usually should be occurring because of spleen. When the phagocyte takes a chunk of it. So this would be a bite cell.
So it only takes a bite.
Unless the hemoglobin precipitates in one corner. So if this is a red blood cell, this is bite cell. You took a bite out of it. Like a donut or whatever. I don't know why I keep talking about food always. Okay, so that's bite cell. What else could you see? Heinz bodies. Now Heinz bodies precipitated hemoglobin, and that will be somewhere in this area that you will see something dark in one corner of red blood cells. Can you guys see that dark? A little. Okay, so let's make this a little bit lighter. So when you have hemoglobin precipitated in one corner, and that part of the RBC will occur a little bit dark, that's Heinz bodies. Okay. It just simply tells you hemoglobin precipitation within red blood cells. Okay, so these are on the smear. You will see shapes, right? Shapes. You can also see something known as hypersegmented, but they are now hypersegmented, not red blood cells. That should be neutrophils. That's only with megaloblastic anemia. Hypersegmented neutrophils. You will see that. Again, each appropriate term is under each category of anemia. Okay, so I'm just talking to you in general. What are the possibilities you will be looking for? Okay. If you see hypersegmented neutrophil, you will only think of macrocytic anemia, megaloblastic anemia, only of that. No other anemia has that. Okay. Fragmented RBCs are you're only restricting from all 20 anemias to 8. These are only hemolytic anemias. Okay. Now, let's come back to two more things where Said was asking. Mean corpuscular hemoglobin concentration. That's not on a smear. You will test that based on CBC or plasma test. It's